So many patients nowadays have pacemakers or defibrillators for their cardiac disease, particularly as they're getting older and now develop cancer. And some cancer treatments, particularly left breast cancer and cancers on the left chest wall or in the mediastinum, require radiotherapy as part of their treatment. And radiotherapy is a high energy therapy, either through protons or neutrons, and we now know that this can affect the electronic circuits in these pacemaker and defibrillators. So this is complex. It requires planning with the radiation oncologists to calculate exactly where the dose is being delivered. They've got very clever ways of focusing the dose more and more to try and avoid devices. The total dose which will be delivered, and from that we can decide, is it safe to proceed? Do we need to switch off the device before treatment and switch it back on afterwards, because it can interfere with sensing and monitoring? Obviously that's not possible if someone's pacemaker dependent. And then finally, in some cases, should we move the device away from where the therapeutic radiation field will be? There's another way of looking at this. There are miniature devices such as reveal devices and loop recorders, which we may start using in cancer patients and cancer survivors to pick up arrhythmias early before they develop and cause complications such as stroke from atrial fibrillation. So not only is there the issue of how do we move them away from radiotherapy, but more and more the role of new devices for treatment benefit. So there's a whole range of complications of cancer treatments. In 2016, the ESC had a position statement on cardiovascular problems in cancer, and it covers the whole syllabus of cardiology. Heart failure is a main part, but arrhythmias, valve disease, coronary disease, pericardial disease, electrical diseases. We've talked about arrhythmias. There's also heart block, sinus node disease. All these could be potentially the problems of cancer treatments. If we think about heart block, there's a whole new group of cancer treatments called immune therapies, checkpoint inhibitors, that are revolutionizing some cancers. They can cure people with metastatic melanoma, but we're learning that these drugs can cause myocarditis in some patients, leading to ventricular arrhythmias. But in other patients, they're developing heart block without myocarditis overtly. Ventricular function remains normal, but these patients may need urgent pacemakers. This is a person with metastatic cancer, but actually a potential cure. So we must offer them the best modern cardiology care. So over the last 10 years, we've seen the growth of specialist cardio-oncology services, particularly in tertiary centres which have large oncology departments and oncology services with all the new drugs being used. And by bringing all the specialist expertise under one umbrella, then we can give the best care to treatments. Prevention is key, and supporting the best oncology care is key. We published our own data from the Royal Brompton Hospital last year, and we were able to support 90% of patients who had complications back onto their optimal cancer treatment. The ESC Cardio-oncology Council has been set up and created recognizing the importance of this topic in Europe and beyond. And last year we published a paper on how to set up a cardio-oncology service. And I think the larger tertiary centres and university hospitals can be the hub, but link into smaller community and district general hospitals, as we do for complex valve disease, complex arrhythmias, so that all the patients can get access to the expertise. And of course, this also allows training, because we'll need consultants of tomorrow to be experts in understanding this new field. Oncology moves really quickly, so to keep on top of the latest developments requires a new subspecialty within cardiology, which is what we're now seeing.